not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He, got his wrist pain by doing over-aggressive high fives to his buddies.
Hello, Ultrasound Podcast listeners. Welcome back. We've got another treat for you again today. We have the Bone Boss.
Can you start over and say that with some energy and some excitement?
No.
Okay.
Hello, Ultrasound Podcast listeners. We have got an incredible episode for you today.
We can't tell you how excited we are today to have Mark Goodman here with us.
The Bone Boss, the
man.
musculoskeletal master.
The myth, the legend.
He is back again for a third podcast. So I hear, Mark, you're going to teach us about hips today. I think the main reason we asked you on is because of the horrible mismanagement that Mike recently had in a pediatric case of a hip complaint. Mike, you want to tell us about that patient?
Yeah, so admittedly, I don't do a lot of hip ultrasound. Don't have a lot of experience with it. I'm too busy playing around with the heart. So when an 8-year-old child with Down syndrome comes into a small community hospital that I'm working at, I guess this was just a few months ago, and complaining of just not feeling right, it sort of confuses me a little bit. So this was a little tyke that was 8 years old, and he wasn't feeling right. He was acting weird, according to the parents, which is always what you want to hear when you're dealing with pediatrics, right?
I mean, it just gives you so much to go off of at that point.
Lots of stuff to go off of. So we just kind of, in interacting with him, we finally figured out that he wasn't quite moving one of his legs the way he normally should. And I mostly got that from the parents because I sure didn't pick it up on physical exam. And what ended up happening was, over the course of about 12 hours, I ended up diagnosing this kid with septic arthritis, but it required 4 different sedations, a trip to X-ray, a trip to MRI, a trip back to IR to get an ultrasound or to get an IR-guided hip aspiration. I mean, it was ridiculous. It took me the entire day to get this kid dispoed, and not only that, but he was sick the entire time, so it took that long to really get him to definitive care. So what I'm hoping, Mark, is that you can teach me how to do all those things myself, so I don't have to continually sedate the kid. I don't have to send them over to radiology multiple times under sedation. It was a nightmare.
Not that any of those things were wrong, maybe, but I might have gone about it a different way. Instead of the forced sedation, just maybe aspirating the hip in the emergency department yourself could have saved you a lot of hassle. So
well, that'd be great if I knew how to do it.
Yeah, it wasn't that you were wrong. You just did a horrible job. So
it's not that I'm a bad doctor. You're just a terrible doctor.
So the diagnosis of hip effusions and ultrasound to guide an aspiration of the hip joint and an injection of the hip joint are something that are kind of typically outside of the practice of the regular emergency physician. But I don't think it really needs to be. And what I'm hoping to do today is talk you through this process so people like Mike, who are pretty average at most things, could even perform this themselves.
Don't talk me up, man. Don't talk me up.
In the emergency department. So this is something that is relatively straightforward. If you know your landmarks, if you know what you're looking for and have a good sense of what you're doing with the ultrasound, this is something you could be doing yourself and hopefully saving a patient a lot of extra work and time with all those consults and going to IR and back and MRI and all those different things.
Sweet, let's do it. I can't wait to hear about it.
So a case like that, you definitely need synovial fluid to make a diagnosis. And in order to do that, typically a patient needs to go to interventional radiology, have a fluoroscopic guided hip injection, or you need to get an orthopedist in who's going to either take that patient to the operating room to get a synovial fluid sample or to wash the joint out. And all those things, especially in a smaller community hospital, are going to take a lot of time and effort to do. So I'm going to show you how to go through a ultrasound-guided hip aspiration, diagnosis of a hip effusion, and then a ultrasound-guided hip injection in the emergency department. But before we get to that, I guess the question comes up is who really needs ultrasound to do these? And there's some literature out there looking at ultrasound-guided hip injections that shows that the accuracy of all joint injections is actually improved quite a bit.
So, Mark, it makes sense to me that ultrasound is going to make you much more accurate for getting into these joints, but which joints exactly and what kind of injections and aspirations are going to help you with? Because recently, I taught an orthopedic group some injections, and they kept saying over and over, well, I'm never going to use ultrasound for subacromial bursa or for knee injections because that's really easy. Are there any numbers on that? Are they right about how easy those are?
So there actually is some data on that, and it is something that I kind of agree with them. I usually think that a knee injection or a subacromial bursa injection is pretty straightforward based on landmarks, but unfortunately that's not really true. In the studies that I found, it shows that our accuracy is really not as good as we were hoping for. So without ultrasound, the accuracy of a subacromial injection was about 63%, a knee injection or hip injection was about 79%, and all those improved to between 95 and 100% with using ultrasound. And this is in experienced clinicians who have been doing a lot of these injections. So I think even if you've done a lot of these, you have something to learn and can improve by using ultrasound in your practice. And just to kind of reiterate that point, there's this study in the rheumatology literature showing that they took a trainee with an ultrasound machine and compared it to an experienced rheumatologist using clinical exam. And the trainee actually had a lot better accuracy with doing joint aspirations and injections than the experienced rheumatologist did. So if you have the clinical skills of Matt Dawson and then an ultrasound machine, you'll probably be pretty much unstoppable.
So how exactly does ultrasound improve these aspirations and injections?
I think the biggest thing is you're able to see with your needle exactly where you're going. You can visualize that fluid either in the joint or in a bursa and put your needle directly into it. And you can also minimize the risk to the patient by avoiding vascular structures and nerves that are nearby.
So I guess it's important that aspiration literature is pretty important too, because sometimes you don't really have a big effusion that you're going after when you're trying to diagnose these septic arthritis patients, or for whatever reason you're trying to get fluid. So they often talk about, I know sometimes they actually inject a little bit of sterile saline and then pull it back out to see if there's anything in that. So I guess I was initially thinking that, I don't really care as much about actually injecting because I'm probably not going to be doing that in the emergency department. I'm really interested in pulling off that effusion, but sometimes there isn't really that much of an effusion.
And I think that's one of the biggest things is if you can look at a knee or a hip and say, that's just swollen, but there's no effusion to really go after, you're going to save the patient the risk and the pain of putting a needle into that joint and trying to get fluid back. So I think the first questions that comes up with talking with emergency physicians who've typically not been doing this is, can I do this? Is this something that's within my scope of practice? Is it safe for me to be doing this in the emergency department? And the short answer is yes. You have the ultrasound skills from your training, from doing central lines, fast exams. You're facile enough with the ultrasound that you can be doing this in the emergency department. There's a couple case studies here and a recent case report in the annals that describes doing this in the emergency department, and it's actually been around for quite a while. The radiology literature goes back to the 80s, and then Steve Smith from Hennepin actually did a study in 1999 describing this technique. And out of all these case reports, this was well tolerated with really no complications.
So if I can measure diastolic dysfunction, then I can aspirate a hip joint. Is that what you're telling me?
I'd say so. I think you're probably right on track.
What if I can't measure diastolic dysfunction?
Then you can probably still aspirate a hip joint.
All right, good.
The second question that comes up is this safe to do? And there's some good data on this from the radiology literature showing about 800 patients that had an ultrasound-guided hip injection, and none of those went on to have any kind of iatrogenic infection complication from the femoral artery, nerve, or vein. And typically these are done in fluoro, which I actually think has a disadvantage over ultrasound. In fluoro, you're not really able to identify the femoral vessels and the femoral nerve, whereas on ultrasound, you can really clearly see those and avoid them when you're doing this aspiration. And then, what about pediatrics? Like Mike's case that he had, there's some data on this as well showing that the aspiration of hip joints in kids is also something that we can do. You can even measure the synovial thickness and try and determine whether or not that hip has an effusion. That's something that is a little bit beyond the level of this podcast, but I think just looking like we're going to describe and seeing if there's a fluid collection and comparing with that contralateral side are probably the best tools you have. Second study in 2009 showing peds EM trained doctors trying to diagnose effusions, and they were actually really good with very minimal ultrasound training. They got about 10 minutes of ultrasound training to look for a hip effusion, which could really help with your diagnosis in a pediatric patient, the limp. Their sensitivity was pretty good, around 90%, and when they got their skills up, they actually had even higher sensitivity than that, with a positive predictive value of 100% and negative predictive value around 92%.
So I was obviously joking about the Blavis comment, but to be serious, that kind of annoys me sometimes, some of these studies, when the masters of ultrasound are the one doing it. I really, really like this study where you talk about patients with minimal training, or you talk about the stuff that Jang does with the 10 minutes of training in ultrasound. This makes me feel a lot better that anybody can do this, that we can definitely learn this and do it.
So how would you go about doing this? Well, your landmarks are going to be the femoral neck is what you're really going to be looking for. And if you think about that, you're going to be about 30 degrees off of the axis of the shaft of the femur and pointing towards the pelvis. So you're going to want to line your ultrasound probe up over the femoral neck so you're getting a view looking over the femoral neck over the ball of the femur.
And this is an important point. I think a common mistake is that people want to line the probe up with the femur, but the hip joint isn't in line with the femur, 30 degrees.
So are you going to see the vessels? Are you going to see the femoral, like the femoral bundle when you're looking at this? Or?
Yeah, so you're actually not going to see it in this view, but we're going to talk about actually going through the process you'd use for a hip aspiration and how you'd go about identifying those vessels and then marking them so you can safely perform this. So this is just getting the view you'd need to look for an effusion to start out with. So you're looking over the femoral neck, and you're going to get a view that looks like this. And what you're seeing there is the femoral head on the left side of the screen with the joint capsule kind of wrapping around over the top of that and coming into the femoral neck. And that joint capsule comes in and covers the femoral head and neck and is a good place to look for fluid underneath there. So if you do have a hip effusion, what you're going to see is a dark hypoechoic area lifting up that joint capsule over the femoral head and neck. And you should be able to see this pretty easily, and it's always good to compare with the other side to be sure this is actually a pathologic finding.
So I might be jumping the gun here, but I'm just curious. So if there is an effusion, but you're still going to try to aspirate, are you just basically going to push down to bone and then just draw back and see what you get?
So what I'd try first is I'd probably put the knee in a little bit of flexion and some internal rotation, and I'd see if I could visualize a small effusion there. If I still don't see an effusion, I think I'd be pretty hard pressed to put a needle in and try and get some fluid out of that joint.
Okay, so you're gonna use this mostly in the patients with sort of a higher pretest probability, somebody who's got an effusion. You're not going to say, well, they got hip pain, I got to make sure it's not infected.
Exactly. Yeah, I think you have to really be thinking that this patient has infection and that you need fluid one way or another. If this patient has no effusion, you're still concerned, that's someone I'd probably send over to radiology and have someone else do this. We're really talking about kind of picking the low-hanging fruit here in the emergency department with the patients that are going to be an easy aspiration for us to do.
So you lack confidence.
So you're not going to rule out a hip effusion with ultrasound. Is that what you're telling me? Because you show the study of about 90% sensitivity when physicians were confident in their ability to perform this.
So I think you can accurately look for a hip effusion, but if you decide you need fluid from a joint with no effusion in it to really make your diagnosis, then I think you're going to be in a little bit tighter spot trying to put a needle into a joint with no effusion and getting fluid back.
I can buy that. I don't think I'd get excited about sticking a needle in a dry joint.
So here's a second look at a joint with a pretty large effusion there. You can see that large hypoechoic area surrounding the femoral head and neck, and that makes a pretty easy target for an ultrasound-guided aspiration.
This really doesn't look nearly as scary as I thought it was going to, Mark.
So we'll see the femoral vessels here in a second. That'll get you.
Okay, that'll give me a little more feared.
There's some data out there looking at acute versus chronic effusions. If you could diagnose those using ultrasound, measuring the synovial capsule itself, and I think that's probably less relevant for us in the emergency department, maybe more so for rheumatologists. I think the bottom line is if a patient has a fever, hip pain, and effusion, you probably need to get some fluid out of that joint to be sure this isn't a septic process. So there's some advantages of doing this under ultrasound instead of fluoroscopy, the biggest being the lack of radiation, the ability to visualize those soft tissue and vascular structures, and the biggest thing I think is being able to do this at the bedside in the emergency department, not having to take the patient to a fluoroscopy suite to get this done.
Or sedate them 4 times.
So it's also very cost effective. Mark and I actually recently taught an orthopedic group some injection techniques and aspiration techniques, and they were telling us about a patient that they sent out to have a fluoroscopically guided hip injection, and the patient got a bill for $5,000. And this was something that they brought a couple of their patients in that day, and they did on their patients with us helping them in a few minutes, and it definitely saved their patient a lot of money, and it was a successful injection.
$5,000.
Yes, for a fluoroscopic. I don't know. I'm sure that the payers didn't pay that. I don't know what they paid for it, but it was just an incredible story to hear.
That's
for
crazy.
Something that took a few minutes, literally in the office.
That, and I think if you're doing this at 2 a.m, you could be hard pressed to convince a radiologist to come in and do this in your small community hospital, especially if it's something that you can do by yourself at the bedside.
Man, I'd do it for $20 and a 6-pack of beer.
So there is some data looking at how accurate ultrasound hip injections are when compared with fluoroscopy, which I think we can generalize a little bit to aspirations. And they looked at ultrasound versus fluoroscopy and found they were actually about 97% accurate in patients with a wide range of BMIs, up to about 39. And on average, this took about 2 minutes to perform, so a pretty quick procedure to do. And the one patient that they missed in this study, they dislodged the needle when they used the connection, when they attached the connection tubing. So probably closer to 100% when looking at this versus fluoro.
So that's great, but what about the really, really big patients that you have? I mean, that's always the question, right? The hip joint is on down there. If you have a really, really fat patient, is ultrasound still going to be useful, or do you need to do it fluoroscopically guided then?
So your approach to doing this, you're going to want to start with your linear probe in a cross section of the neurovascular structures in the hip. So you're going to want to be looking kind of in line with the inguinal ligament across the femoral nerve artery and vein, so you can really delineate those structures. Once you see those, you're going to want to switch to the curvilinear probe and then Doppler again before you do your injection, so you can identify the circumflex vessels, and then use that curvilinear probe for your needle guidance. And we'll go through those steps. So I think Matt Dawson actually coined the 25 P's of joint injection, which include a pre-scan, prepping the area, the probe placement, poke, the push of the medications or the pull of the joint fluid, a pray, and then the last P is the high fives at the end, which might be spelled with a P somewhere.
I actually think of this as more of a mnemonic because it spells out pa. So that's the easiest way to remember the steps to do this, in my opinion.
So all I've got to do is just pa.
Exactly. Yeah.
You know,
I think you missed a P.
When
there
I'm rehearsing those steps in front of the patient, it's going to be really awkward.
So start with your linear probe and identify the femoral vessels. And this is something you should be used to doing for femoral lines, femoral nerve blocks, and just mark those and get a good idea. Those are going to be quite a bit medial to where you're going to be doing your injection. So you can either mark that with a pen or just keep a good idea in your head where those are going to be. Once you identify those, get that same view that you were looking at with a diagnosis of a hip effusion with your curvilinear probe right in line with the femoral neck. When you do that, put some color flow on and identify the circumflex vessels coming around the neck of the femur. Those are going to be good to avoid when you're doing your injection.
So, Mark, when you do this particular aspiration, do you wear gloves or do you do it like you did in this picture that you're showing?
So usually I lick my fingers first,
Okay.
and then I'll actually hold the probe with one toe.
Maybe go use the restroom and then come back without washing your hands.
So this is what's called an example, Mike. It's just it's not an actual
So
patient.
it's actually sterile when you do it.
Yeah, so I think this is something that everyone has their own kind of ideas of how sterile this needs to be. For me, I think this is something where you should have a full sterile prep, a sterile probe cover, sterile gel, sterile needles. The risk of causing some kind of infection is something that I don't want to really encounter.
It's kind of like you're sticking a needle in a petri dish. So I'm pretty sure you don't want to be injecting any bacteria.
Exactly.
So I got to be honest, though, I say something about the whole neurovascular structure there. When I've seen this done, I mean, when we do this, we're pretty much always quite a bit lateral to where those are. So it's great to look exactly like you're talking about, but everyone finds you're not really that close. So don't be scared by these pictures we show you here. Once you take a look yourself, you'll see that you're not really right there on the vessels.
You should be quite a ways away. I think when you're doing a couple of these initially, though, it's a good idea to get a view of that anatomy in your head and realize that you need to be quite a bit lateral to that. And you're not going to really see the view you need to do this aspiration unless you are lateral. So
Absolutely. I mean, the pre-scan is the PA and the PA. So you have to do the pre-scan, but you're going to be quite a ways away from those vessels.
I think that the next P is the prep, which Mike actually touched on. So I'll usually use sterile gloves, gown, mask, full sterile drape, as well as probe cover and sterile gel when doing this. And a patient that's a little bit thinner, you can use a 2.5 inch 22 gauge spinal needle, which is going to be the most helpful with some IV connection tubing attached to a syringe for your aspirin. And in a patient that's bigger, you could use a 3 or 3.5 inch needle.
And the spinal needle really is key here. If you try to use a normal needle, you're not probably going to make it all the way down unless you get really steep with your angle, in which case at that point you're not going to be able to see your needle well.
Yeah, the steeper you get with that needle, the more difficult it's going to be to see where you are on the ultrasound.
Does it matter bevel direction at all? Does that have anything to do with anything?
So you can get kind of fancy with your bevel control, which is going to determine which way your needle goes when you're actually pushing the needle in through the skin. I think it's good to start with the bevel up just to get a good idea of where things are going to go, and when you do your aspiration, you're going to be in the right area. So once you're in that effusion, you should be able to withdraw synovial fluid from that point. And after that, you're pretty much in the clear. Pull the needle out. And I think the pray and the high five at the end were the last two P's in the steps there.
So just, all we need to remember is puppa, 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 puh.
I think that was one too many P's.
Oh, man. God, I'm never going to be good at this.
So I think while we're talking about the hip aspiration, maybe we should just touch on hip injections also, because it's pretty much the same process and can also be useful for some of these patients in the ED.
Yeah, I think that's a great idea. So tell me how you use hip injections in the ER.
So I think there are really a couple roles here. Actually, it worked last night. I had a patient who was unfunded immigrant who had terrible left hip osteoarthritis. He'd actually been in to see an orthopedic surgeon who had scheduled him for surgery and then canceled the day before when he realized he didn't have any insurance, and had had this terrible chronic left hip pain for about 6 months now, to the point where he's barely able to walk. So in addition to getting him set up with case management and trying to get him set up with an orthopedic surgeon to talk about hip replacement, I did a hip injection on him with some bupivacaine and some steroids to try and temporize things until he was able to do that. And it was actually pretty rewarding. He had full relief of his pain and walked out of the emergency department after he did his injection.
And there are going to be definitely people that argue whether or not hip injections in the ER, if that's really appropriate, what's the standard of care and what's not. But I mean, I think you gave that patient some great care. Another way that I've used it recently is I had a patient who had a lot of hip pain, and it was unclear really whether the patient was osteoarthritis or actually more sciatica. We did an injection, didn't use any steroids, just lidocaine, and the patient's pain got completely better after an injection into the joint. So that was pretty diagnostic for actually osteoarthritis instead of sciatica. And there's a couple studies showing that that is useful and that is a real technique and not something that we just made up.
Okay, so I still want to get you guys to commit on this. So you're doing an injection to the hip. So you're going to stick the needle and go where? Are you going to put it right under that capsule and put it right next to the bone? I don't understand where
exactly.
Where does the injection go?
Yeah, your target's going to be pretty much the same. You're going to want to be aiming right to the junction of that femoral head and femoral neck, and the normal joint capsule in a hip without an effusion is going to be a little bit difficult to see. You're not really going to be able to see that layer of fluid underneath there. So you're going to go in until you hit the bone and then pull back just slightly. And once you see that, your injection should flow pretty easily. From that point, you can look with the ultrasound and actually see the capsule filling up, which is going to look like an effusion.
So, and by the capsule filling up, you mean the fluid is going to run up around the femoral head.
Exactly.
So I'm injecting below the femoral head, sort of where the head meets the neck, and then I'm going to see an effusion start to create around the head itself.
And remember that joint capsule actually extends down the femoral neck as well, so you can get some fluid going both directions, and that's normal.
I think that's key, though, because, I mean, if I had just done this without talking to you guys first, I probably just would have aimed straight for the head, but it's not. It's to the neck.
Right, and an important point is that capsule actually comes all the way down and attaches at the base of the femoral neck. So you could be a little ways away from that head. Actually, you want to aim exactly where Mark was talking about, but if you're a little lower, you're probably going to be in the capsule when you inject. And the flowing easily is a very important thing too. If it's flowing easily and you're not seeing it kind of piling up somewhere, then it's filling into the capsule.
That's great, Mark. I can't wait to try this. I think this is a really interesting concept. And I mean, obviously, the aspiration of the hip is something I've been dying to do forever because it drives me crazy sending people over to IR when I know we can do these things with ultrasound. But the injections are pretty interesting too. And maybe I'm not going to be doing this on every patient that I see in the emergency department with hip pain, but as a diagnostic tool, as Matt was mentioning, or especially in those unfunded patients that are otherwise not going to get any care and sit around being miserable all day long, maybe I can do a little good. So thanks.
Yeah, thanks.
Thank you.
And if you guys, if you thought this was a little too complicated or whatever for the emergency department, you're going to love our next podcast. We've actually got Mark on for 2 hours talking about bevel control. So look for that coming up very soon. you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.